There is a word that has sent more women over 60 into unnecessary suffering than almost any other word in modern medicine. The word is routine. Your doctor says it, and somehow the question disappears from your mouth before you can ask it. Routine colonoscopy, routine bone density scan, routine prescription for sleep medication, routine follow-up procedure. And you nod because they are the doctor and you trust them, and because somewhere along the way we were taught that questioning a physician is rude or dangerous or both. I want to tell you something my grandmother Rachel told me when I was still a young medical student, before I had learned enough to be truly dangerous. She was in her early 70s then, sitting at her kitchen table in Brooklyn, her hands around a cup of tea. She had survived things I will not name here. She had buried people and rebuilt herself. And she looked at me in my white coat and she said, "Sarah, the best doctor is the one you carry inside yourself, the one who knows when to ask why." I spent 40 years after that moment in the field of preventive medicine, working with women in Israel, in New York, in Miami, and for the past several years here in Boca Raton, trying to understand what she meant. And I believe what she was pointing to was this: Jewish medical tradition, from the Torah through Maimonides through the Talmud, has never viewed medicine as something that happens to you. It is something you participate in. You are not a passive recipient of procedures. You are a guardian of something sacred. In today's teaching, I am going to share with you 5 procedures and medical interventions that I, after 40 years in medicine and after studying the wisdom my grandmother Rachel left in her notebooks, would not agree to without a very serious conversation, without asking hard questions, without understanding what the science actually says versus what has simply become habit in the medical system. This is not about distrusting your doctor. This is about honoring one of the 7 Jewish laws of longevity that I have spent decades documenting. Today, I am sharing Law 5, the law that governs what we put in and what we allow to be done to the body we have been given in trust. And toward the end of this teaching, I will share something from my grandmother's notebooks that she said she only told women who were ready to hear it. Something about the single most important question you can ask in any doctor's office at any age. I need you to hear this. Not because it is frightening, but because your health after 60 depends not just on what you do, it depends on what you understand. I grew up in 2 worlds. I was born in Tel Aviv and raised between Israel and Brooklyn, between the Hebrew University Medical School where I trained and my grandmother Rachel's kitchen, where I received a different kind of education entirely. Rachel Levine was born in Łódź, Poland in 1921. She lived to 98 years old. She took no medication until she was 90, not because she was lucky, because she understood something about the body that I spent most of my career trying to translate into the language of modern medicine. She kept notebooks, written in Yiddish with a little Hebrew, filled with remedies, with observations about food and fasting and rest and community, with passages she had memorized from Torah, and with questions, always questions, about what healers were doing and why. When I was 45 years old, I went through a period of such profound fatigue and cognitive fog that my own colleagues could not find the answer in my blood work. I opened Rachel's notebooks for the first time with real desperation. What I found there changed the trajectory of my career. One of the things I found was this: my grandmother was deeply skeptical of interventions that had not been tested by time. She did not oppose medicine. She had seen medicine save lives during the most brutal period of the 20th century. What she opposed was medicine that had become reflex, medicine that had become routine without wisdom. Before I go any further, I want to ask you to do something. Type in the comments right now. I am my own guardian. Just those 4 words. Because the first step in understanding any of the 7 laws of longevity is remembering that Shmirat HaGuf, the obligation to guard the body while summing, is not your doctor's responsibility. It is yours. They are your partner, but you are the guardian. Now let me tell you what we are actually looking at today. According to research published in JAMA Internal Medicine, Americans over 65 receive more low-value medical care, defined as care that provides little or no meaningful benefit and may in fact cause harm, than any other age group in the developed world. More unnecessary procedures, more medications that interact badly with each other, more screenings that lead not to better health but to more procedures, more anxiety, and in many cases, more measurable harm. The American Geriatric Society publishes what is called the Beers Criteria, a regularly updated evidence-based list of medications and interventions considered potentially inappropriate specifically for older adults. Most women I have worked with have never heard of it. Their doctors may use it as a reference, but it is rarely handed to the patient and almost never explained. This is not a conspiracy. It is a system that was built for a different purpose, for acute care, for crisis management, and it has been slow to adapt to the reality of what a 60, 70, or 80-year-old body actually needs to thrive over decades. Maimonides understood this 800 years ago. In his Regimen of Health, written for the Sultan Saladin in 1198, he wrote something that stopped me the first time I read it in medical school. He wrote that the physician who knows only how to treat disease knows only half of medicine. The physician who teaches the patient how to live without disease knows the full art. He was not against intervention. He was against intervention without wisdom, against reflex without understanding. He was a physician and a rabbi simultaneously, and he never saw any contradiction in that. The body and the soul were one system, and every decision about that system required full awareness. This is the spirit behind what I am about to share. These are not 5 procedures to fear. They are 5 procedures that deserve your most serious, most informed, most Maimonidean attention. The first is long-term proton pump inhibitor use. These are the medications most commonly known by names like omeprazole and pantoprazole, the drugs prescribed routinely for acid reflux, heartburn, and stomach discomfort. They are among the most prescribed medications in the world for adults over 60. And here is what your physician may not have told you. They were originally approved for short-term use of 8 to 12 weeks. Multiple large studies, including analyses from Stanford University and from European research consortiums, have linked long-term PPIUs, meaning continuous use, over months and years, to significantly increased risk of magnesium deficiency, vitamin B12 depletion, increased susceptibility to intestinal infections, including Clostridioides difficile, and in several longitudinal studies, measurable increased risk of chronic kidney disease and dementia in older adults. My grandmother had a phrase for what happens when you suppress a body process rather than correcting its cause. She called it pushing water under the rug. It does not disappear. It finds another room. The question to ask your doctor is not whether this medication is relieving your symptoms. Of course it is. That is what it does. The question is, what is causing the acid problem in the first place? And what would it take to address that root cause? In Jewish dietary tradition, and this connects directly to Law 3 of the 7 laws, the law of clean foods, eating patterns, food combinations, and the timing of meals have been understood for 3,000 years to profoundly affect digestive health. The laws of kashrut contain embedded wisdom about separating certain food categories, about the interval between eating and rest that modern gastroenterology is only now beginning to examine seriously in controlled research settings. The second intervention I want you to think carefully about is the routine prescription of benzodiazepines and Z-class sleep medications for sleep disruption. This has become an epidemic in women over 60. These medications are handed out in primary care offices across America with a frequency that would have shocked physicians 40 years ago. The American Geriatric Society's Beers criteria has consistently listed this entire class of medications as potentially inappropriate for older adults, specifically citing increased risk of falls, hip fractures, motor vehicle accidents, cognitive impairment, and physical dependence that develops faster and resolves more slowly in aging bodies. A landmark study published in the Canadian Medical Association Journal followed over 3,000 adults over 65 and found that those who used benzodiazepines regularly showed a significantly elevated risk of developing Alzheimer's disease. This finding has been reproduced in multiple subsequent analyses. Here's what I want to tell you from my own 4 decades in medicine. Sleep disruption in women over 50 is almost never a benzodiazepine deficiency. It is almost always a signal. It is the body asking a question that the medication silences without answering. The question might be about cortisol rhythm. It might be about light exposure and melatonin suppression from screens. It might be about unresolved anxiety or grief or transition. And here is something from the Talmud that I have thought about for years. The hour of 3 in the morning, the hour when so many women over 50 lie awake, is described in rabbinic literature as a liminal time, a threshold hour particularly suited to reflection, to prayer, to the kind of thinking that does not happen in daylight. My grandmother never slept a solid 8 hours. She slept perhaps 6, woke in the night, prayed and wrote in her notebooks and thought, and then slept again before dawn. She called those night hours her most honest time. Her mind at 98 was sharper than most people I knew at 50. I am not telling you to romanticize sleeplessness. I am telling you that the first question before any prescription should be, what is my body trying to tell me? The third area requires particular care because it touches on cancer screening, which is deeply emotional territory. I am speaking specifically about the continuation of aggressive cancer screenings, including colonoscopies, mammograms, and certain CT and PET imaging for women over 75 who carry low-risk profiles and who are otherwise in reasonable health. The United States Preventive Services Task Force, the USPSTF, which sets evidence-based screening guidelines for American medicine, recommends that routine colonoscopy screening be discontinued at age 75 for average-risk adults. For ages 76 to 85, they specify that the decision must be individualized based on the patient's overall health and values. Beyond 85, the evidence does not support continued routine screening. Why does this guidance exist? Because the risks of the bowel preparation, the procedure itself, and particularly the anesthesia required, combined with the reality that many findings in this age group would be monitored rather than aggressively treated, mean that the risk-to-benefit calculation has genuinely changed. A similar individualized analysis applies to mammography in women over 75 with other significant health considerations, where the USPSTF notes insufficient evidence that continued routine screening reduces mortality in this population. This is not nihilism. It is not giving up. It is individualized medicine. Maimonides returned to this principle in nearly every chapter of his medical writings. Treatment must always be measured against the specific constitution of the specific person in front of you, not the average patient, not the protocol written for a population, but this woman, this body, this stage of life. The question to ask your doctor is direct. Given my particular health profile, my constitution, and what I want from this stage of my life, what does this screening specifically offer me? And what are its real risks for someone of my age and health status? The fourth area is polypharmacy, the simultaneous management of multiple prescription medications. The average American woman over 65 takes more than 5 prescription medications daily. Many take 10 or more. Drug-to-drug interactions do not add, they multiply with each additional medication. The Beers criteria identifies dozens of combinations particularly dangerous for older adults that remain common in clinical practice, largely because each medication was prescribed by a different specialist who may not have full visibility into everything else the patient is taking. In Tractate Bavakam of the Talmud, it is written that permission was granted to physicians to heal, not to overwhelm. There is a teaching in Pirkei Avot, do not add to that which is sufficient. I have watched women come into my practice carrying bags, literal shopping bags, full of prescription bottles. And the first thing I have often done is sit with them for an hour and go through every single one. What is this for? When was it prescribed? What were the circumstances at the time? Has anyone ever reviewed whether it is still necessary or whether it is now creating problems that other medications are being prescribed to address? This process, called medication reconciliation and deprescribing in modern medicine, is now recognized as one of the most valuable services a physician can provide to an older adult. And yet it almost never happens unless the patient specifically initiates it, ask for it. You have the right to understand every substance entering your body every day. In Jewish law, the body is not yours to neglect or to surrender without understanding. Tselem Elohim, you were made in the image of the divine. To treat that body as a passive recipient of whatever is prescribed, without question, without comprehension, is not reverence. It is abdication. The fifth area is elective surgery undertaken without full understanding of anesthesia risk in the older adult. I want to be precise here because I am not speaking about necessary surgery. Surgery saves lives. Surgery restores function and dignity and independence. What I am speaking about are elective interventions, procedures chosen for comfort or convenience rather than urgency, where the anesthetic risk in adults over 65 accumulates in ways most patients are never fully informed about. Postoperative cognitive dysfunction, physicians call it POCD, is a documented and serious phenomenon in which older adults experience measurable declines in memory and cognitive processing following general anesthesia. Studies published in Anesthesiology and in the British Journal of Anesthesia have documented that between 20 and 40% of older surgical patients experience significant cognitive changes in the weeks and months following a general anesthetic. For some patients, these changes resolve over time. For others, they do not fully resolve. For patients who are already at the beginning of any cognitive vulnerability, the risk is amplified further. This is not a reason to refuse necessary surgery. It is a reason, with every elective procedure, to ask whether the timing is right, whether the benefit genuinely justifies this particular risk at this particular moment in your life, and whether conservative alternatives have been genuinely tried rather than skipped over because surgery is faster. My grandmother's notebooks contain a phrase she used repeatedly. I translated it years ago for a lecture I gave at the University of Miami School of Medicine. It translates roughly as this: before you agree to be cut, be certain you cannot be healed. It is not a statement against surgery. It is a statement for the pause, for the moment of genuine consideration before the consent form is signed, for the question that sometimes, not always, but sometimes, changes the answer. There is something I want to tell you that I have not said publicly very often because physicians are not trained to confess this kind of thing. Several years ago, I stopped practicing what I teach. I was so consumed with my practice, with writing, with speaking, that I stopped applying the 7 laws with any consistency. I let Shabbat become a concept I quoted rather than a practice I observed. My simcha, my joy, which in Jewish tradition is not a feeling but a discipline, became something I performed for audiences rather than cultivated in private. And I began saying yes to things automatically, recommendations I did not interrogate, prescriptions I did not question even for myself. It took a health scare, not catastrophic but significant enough to stop me, to return me to Rachel's notebooks, to return me to the system. My grandmother used to say, "The laws do not punish you for abandoning them. They simply wait for you to return." We are living in a moment that makes all of this more urgent than perhaps any moment in the last several generations. Physician appointments that once lasted 30 minutes in this country now average 7 to 8 minutes. The electronic health record has rearranged the examination room so that doctors face screens instead of patients. Insurance-driven medicine rewards procedures over conversations, interventions over prevention, treatment over the cultivation of life. This is not the fault of individual physicians, most of whom entered medicine with exactly the same idealism as any healer in any tradition across history. It is the structure. And within that structure, the patient who asks no questions will receive care designed for the average, not for her. What I have shared today is one dimension of Law 5, the law that governs what we allow into the body we have been given in trust, applied not only to food but to every substance and every intervention we consent to. The full depth of this law and the way it connects to and amplifies the other 6 laws in the system is something I cannot compress into a single teaching. My grandmother never taught these as separate lessons. She taught them as a garden. You cannot water one plant and ignore the others and expect anything to truly thrive. Let me close with this. If you do nothing else after today's teaching, I want you to do 3 things. Write down every medication and supplement you currently take and ask your doctor or a pharmacist who is often exceptionally well positioned for this, whether all of them are still indicated and whether any of them interact in ways that could be causing you problems you have attributed to aging. Second, the next time any physician recommends something described as routine, ask one question. What happens if we monitor this for 3 months before deciding? Sometimes the answer will make it clear the intervention cannot wait. More often than you would expect, that question will open a conversation that changes the recommendation. Third, remember the words Shmirat HaGuf. Write them somewhere visible. They mean to guard the body. That obligation belongs to you. In our tradition, the body is not yours to neglect or to surrender without understanding. It was given to you in trust, Tselem Elohim, made in the image of the divine. To question what is done to it, to refuse passivity, to bring your full intelligence into every medical conversation, these are not acts of defiance against medicine. They are acts of the deepest possible reverence for the life you have been given. In my next teaching, I will share one of the 7 laws that I believe is the most invisible and simultaneously the most powerful. A law that most women over 50 have been violating without knowing it. often acting on advice from the very people they trusted most with their health. Subscribe and turn on your notifications so you do not miss it. And if today's teaching gave you something to hold on to, share it with a woman you love who is navigating the same territory. Type in the comments one question you have been afraid to ask your doctor. Just write it. You do not have to know the answer yet. Naming the question is almost always the first step to asking it. Until next time, L'chaim, to life.